So greetings to all the Physio TV viewers. Today we are coming up with another very interesting talk. Before we go on to the title of the talk, let me introduce the speaker today. We have with us today Dr. Neeraj Dhingra. He is a radiation and clinical oncologist with his specialty in cyberknife and radiosurgery. He's practicing at the Ruby Hall Clinic in Pune, along with the Aditya Birla Hospital in Chinchwad, as well as the DY Patil College in Pimpri. Sir has an expertise in management of solid malignancies in all sides of the body and treatment of solid cancers by radiotherapy. He has special interest and expertise in the radiosurgery and cyberknife, which includes SRS, SRT, and SBRT. He has done his MBBS from GMC Meerut and his MD from St. JS Medical College and KM Hospital, Mumbai. His DNB is from Batra Hospital in New Delhi, and he has done his DHM, Diploma in Hospital Management, from NIHFW, New Delhi. He has had a professional journey which has worked in many of the specialty hospitals all over in Delhi as well as Faridabad and Pune, and sir is presently attached with the hospitals just mentioned before. We welcome you, sir.
Yeah, sure. So, good morning, everybody, all the viewers on the Physio TV, and many thanks for the organizing committee for giving me a chance to talk about the role of radiation oncologist in multidisciplinary cancer management. As ma'am has succinctly put, I am Dr. Neeraj Dhingra, and I'm a consultant radiation and clinical oncology and cyberknife radiosurgery at Ruby Hall Clinic and Aditya Birla Hospital in Pimpri Chinchwad. Next slide, ma'am. So the objectives for this talk are to understand basic principles of radiation oncology and learn how radiation therapy is incorporated into multidisciplinary cancer care. Next, please. So oncology, as we know, and everyone is now hearing a lot of cancer cases happening in their family or in their neighborhood. So oncology is basically the study and treatment of tumors. Now we can define tumors into two categories. One is known as a benign tumor, second is known as a malignant tumor, which are also called as cancers. So in the below images, as we can see, there are two pictures. First is of a grade 1 meningioma and second is of a grade 4 glioblastoma. By definition, both are brain tumors, but grade 1 meningioma is a benign tumor. That is, it grows very slowly. It is usually located at the same spot for many years and does not spread to other parts of the body. But the grade 4 glioblastoma are cancers. They are very rapidly growing. They rapidly grow within the parenchyma of the brain and cause neurological symptoms. And even after treatment, they have a tendency of coming back in the post-op area. Next, please. So oncology as a branch includes treatment of cancers by three different modalities. First is, as we are all aware, are surgical oncologists. Second is medical oncologist, and third is radiation oncologist. If we compare them to the three branches of the army, we can say that the surgical oncologist is like the army people because they go in locally, they remove the cancer surgically, and they are mostly involved in the definitive setting or cancer care. Medical oncologist primarily gives chemotherapy and other drugs. So they are like the Navy. They utilize the bloodstream of the body to diffuse and dissipate the drugs throughout the body and cover the cancer or the treatment. They are mostly involved in definitive and palliative care of cancer care. Whereas we radiation oncologists are like the Air Force. We utilize high energy photons for local effect and by killing the tumors locally. And we are involved in both definitive and palliative settings in cancer care. Next, please. All are equal partners in cancer cares, all work together to manage the patients. And as a statistic, we can surely say that around 70 to 80% of cancer patients will require radiation in their cancer journey at some point of time. Next, please. So the treatment modalities, as I have described already, are basically surgery, radiation therapy, and chemotherapy. And a combination of these therapies are utilized for the treatment of all types of cancers. Many times, all three modalities might be needed. Many times, only one or two modalities are utilized. Everything is protocolized and but still every patient is different, and hence individually the treatment has to be tailored to every patient's requirements. Next, please. Next, please. Hello. So when people hear about the word radiation, they often think that it is dangerous, that it is something very dangerous, and it is retained in the body. Somehow, the people in the family cannot come closer to the patient who is getting treated with radiation. So yes, it is radiation is dangerous. There is no doubt about it. But the reality of medical use, the reality of medical use of radiation therapy is very different, as I will explain in this presentation. Next, please. So radiation is basically electromagnetic radiation or waves, which is the emission of energy that comes from a source and travels through space at the speed of light. Now, radiation can be classified into two main categories. One is non-ionizing radiation, and second is ionizing radiation. The example of non-ionizing radiation are the light, ultraviolet rays that we usually see in our environment. And ionizing radiations, where one very common example is X-rays. Now, these X-rays are utilized for treatment, for diagnosis, and they cause changes in the DNA of the body. And that is why they are called ionizing radiation. Next, please. So as we can see along this spectrum, there is the characteristics of a wave. Electromagnetic radiations follow the characteristics of the wave. They have a wavelength, they have a frequency, and there are many type of waves that we usually study in our physics curriculum. So X-rays also fall along the spectrum, which are utilized for treatment in radiation therapy protocols. Next, please. Next, please. So radiation therapy by definition is the clinical modality that deals with the use of ionizing radiation in the treatment of patients with malignant cancers and occasionally benign tumors also. So the aim of this treatment is to deliver a precisely measured dose of radiation to a defined tumor with as minimal damage as possible to surrounding healthy tissue, and it results in eradication of the tumor. Next, please. So as I had already told you one example of X-rays, which are ionizing radiation. The other examples are gamma rays, electrons, protons, neutrons, alpha particles. So the primary modality of treatment on linear accelerators is X-rays and electrons. Gamma rays were utilized when we utilized the older cobalt machines. And protons and neutrons and alpha particles are also utilized in treatment at some or other centers across the world. Next, please. So with radiation therapy, we are treating around all types of cancers. At least all the solid malignancies are treated with radiation therapy in some way or the other. Now, the intent of this treatment matters a lot because this can be curative intent or it can be palliative intent. Now, curative intent means that we are giving radiation with the aim of curing the cancer in the setting. This can be radical intent. That means we are utilizing radiation directly for the cure of cancer along with chemotherapy. The sites, for example, are mostly oropharynx, larynx, hypopharynx, even in lung, esophagus, cervix and uterus, prostate, anal canal. So these are some sites in which we are using directly without the utilization of surgery. Whereas there can be an intent, there can be utilization of radiation before surgery or after surgery, where it is called either neoadjuvant or adjuvant intent. And such examples are brain tumors, oral cavity cancers, paranasal sinuses, cancers of esophagus, stomach, thymoma, rectum, breast, uterus, sarcomas, and even in some lymphomas post chemotherapy, we utilize radiation for consolidation. Now, it's not always that patients who come to us are only treated with curative intent. Some are treated with palliative intent also, because cancers at some many sites of the body cause pressure symptoms or can cause edema, which might lead to symptoms like pain or bleeding, or it can cause even if it suppose obstructs a major vessel. So superior vena cava obstruction can also happen with a big tumor. So the radiation can be given to that focused tumor, localized tumor, with the intent of symptomatic relief. Some examples are in brain metastasis, bone metastasis, spinal cord compression, superior vena cava obstruction. It can be given as a hemostatic RT if it is bleeding from oral cavity or rectum or uterus. And even in cases of carcinomas of esophagus, if there is a dysphagia and patient is not able to eat or even drink, then we can give radiation with the intent of causing symptom relief. So radiation therapy works by damaging the DNA of cells and destroys their ability to reproduce. Both normal and cancer cells are affected by radiation, but cancer cells have generally impaired ability to repair this damage, leading to pronounced cell death. All tissues have tolerance level or maximum dose beyond which irreparable damage may occur. So that is the biological basis of radiation therapy. Next, please. As we are all aware that a cell undergoes a cell cycle, and it is either in the dividing stage or resting stage or a differentiating stage. Dividing cells undergo cell cycle with different uh, phases during this cell cycle, named as G1, S, G2, M, and G0, which is usually a resting phase. G2M is the most active phase of the cell in which the DNA is continuously being synthesized and replicated. And it is at this phase of the cell cycle that the radiation is most effective. Next, please. Next, please. So what happens when cells are exposed to ionizing radiation like X-rays? The atoms or molecules of the cell which are dividing, and probably in the G2M phase, the DNA damage occurs. So the biological effects are the result of this DNA damage, which is the most critical target within the cell. However, there are also other sites in the cell which, when damaged, may lead to cell death. And when directly ionizing radiation is absorbed in biological material, the damage to the cell may occur in one of the two ways, which is either direct or indirect action. Next, please. So the direct impact is that the DNA suffers a single or a double-stranded break directly. So as the energy of the X-rays increases, there is a linear energy transfer which can cause a direct damage of double strand of the DNA, which is an irreparable damage. However, if a single strand is broken, then this can be repaired by the cell, but it takes some time. So this is a direct action of ionizing radiation. And then there is an indirect action of ionizing radiation, in which the water molecules are converted into hydroxide, peroxide free radicals, which then hit the DNA and cause the single or double stranded damages. So direct action causes for around 70% of the action, and indirect action causes for around 30% of the damage. Next, please. So when a cell is irradiated, if suppose it is in its resting phase, then usually it will have no effect. But when it is in its reproducing phase, then it can lead to cell division delay. Most commonly, the cell is killed, which is known as apoptosis, and a reproductive failure can also happen because the DNA has been damaged. Next, please. So there are four arts of radiobiology. That means on these four principles, the radiation effect and the interaction between the radiation and the cell effect can be explained. That is repair, reassortment, repopulation, and reoxygenation. Next, please. Now, a radiation oncologist does not work in isolation. We are usually a team. So the person who leads the team is a radiation oncologist, that is doctors, for example, me. So he is the person who prescribes and oversees the entire radiation therapy treatment. I will prepare the plan, the intent of the treatment, the goal, the dose, entire prescription, side effect management. Everything is managed by radiation oncologists. Medical physicists are the people who basically manage the machines, The treatment planning on the back end is done by them. So the goal is given by me, and they are the people who tailor the dose to the organ, and hence they're the people who are responsible for the calibration and accuracy of the treatment equipment. The machine directly is handled by a radiation therapist. So for example, at Ruby Hall, the machine is functional from 7 in the morning till 7 in the evening. So we are not sitting on the machine treating the patient. It is the responsibility of trained people who are known as radiation therapists who administer this daily radiation under our supervision.